An opioid crisis in America is tearing families apart. Opioids are a class of drugs that include an illegal one, heroin. Synthetic opioids are found in prescription painkillers like oxycodone, fentanyl, hydrocodone, Vicodin, codeine, morphine, and many others. Clemson researchers are looking at various angles of the opioid epidemic. Let's talk about it with our esteemed panel from the Department of Public Health Sciences and the College of Behavioral, Social, and Health Sciences, Drs. Lee Crandall, Rachel Mayo, and Lou Shi. Dr. Crandall, I listed synthetic opioids off the top. We know that they're prescribed to treat chronic pain. When did the medical community realize these drugs were so addictive?
The realization has been relatively recent, and the history of these drugs is that about 20 years ago, the Pain Society began to push the notion that pain was the fifth vital sign, and that physicians should always assess pain and prescribe pain-killing medicines whenever pain was present. Around 2000, the pharmaceutical companies really began then to push opiates and synthetic opiates in particular as the solution to chronic pain, and in many instances argued that the risk of addiction was very, very low. Well, now, 15, 16, 17 years later, we're beginning to see that when people have long-term exposure to these drugs, they often become addicted. Sometimes the physician refuses to continue prescribing them, so they may switch over to heroin because heroin is cheaper than street-level synthetic opiates are. These are epidemics that are really wedded to each other. The addiction to synthetic opiates that starts in the medical settings or sometimes starts through casual use of somebody else's prescription and then leads to heroin addiction. Interestingly, it was introduced as a non-addictive cough medicine by the Bayer Corporation right about the same time that they introduced aspirin. So the two drugs have had a very different trajectory over the last 110 years or so.
Wow. Does this addiction affect any particular group of people, Dr. Xu, or is it non-discriminating?
Of course, it affects everybody, every social demographic group. The kind of group that hit the hardest tend to be male, tend to be middle-aged. They tend to be more likely to be white, and in the rural areas are hit hardest. And region-wise, the Midwest and Northeast experienced the most severe crisis. South is kind of in the middle, and the West Coast is doing a little better than other regions.
Why is that?
I don't know that there's really good research that shows it. Some people believe that the angst that's associated with economic lack of well-being in places like rural Ohio and West Virginia and in the Northeast where jobs are scarce and so forth and people have too much time on their hands and so on is playing into the misuse of these drugs.
Different routes of like those smuggled illicit drugs that come into the U.S. It just happens that the kind of illicit drug that was smuggled into the West Coast, west of the Mississippi River, happens to be a slightly less lethal drug. So the death count from the West Coast is less high. Is lower than the one that that's to the east of the Mississippi River. So essentially, I want to emphasize the point: no region in the U.S. are actually immune to this. It's just like different regions are addicted to different kind of drugs, and some drugs tend to be slightly less deadly than others. I don't want to leave the impression that the West Coast are immune, and we are actually in the South are doing better than the Midwest and Northeast.
And also, some regions are better at responding to the crisis of an opiate overdose with Narcan or other drugs that cancel out the effect of the opiates. So we see regional differences in, for example, whether police officers carry Narcan with them in case they encounter somebody who has overdosed. Here in South Carolina, about half the counties issue Narcan to their police officers and the other half don't.
Dr. Mayo, you're doing some research right now that addresses newborns.
This is an issue, a public health crisis, as we know, in the United States, and it's one of both prescribing and of misuse. And so in many states that we're looking at across the country, there are 100 prescriptions for every 100 people. So almost a 1-to-1 prescription rate. And South Carolina is one of those states. It's very high. So it's not surprising that we'll have women who also become addicted. Even though men are more likely to use, we still see that typically in the populations that we're looking at, in my area of maternal and child health, these are women that have motor vehicle accident, they have a back injury, they're prescribed, one prescription of any of these drugs, and then because they're highly addictive, they become addicted, and then these women become pregnant. And so what we're looking at is a very specific condition called neonatal abstinence syndrome. And these are newborns who are born dependent on whatever opioid mom was taking. We don't say that newborns are addicted because that's a behavioral type thing, but they are born dependent. And so if they're born with this syndrome, it's just like anyone else. They exhibit extreme withdrawal symptoms and even have a high risk of death. We see neurological problems, seizures, they have a risk of cardiovascular events. But if they are treated very early, and if mom is treated during pregnancy with other opioids like methadone or buprenorphine, these are safer drugs, and we know we can give them to mom during pregnancy, and baby will then of course be born dependent on one of those drugs, but they can be weaned down just like an adult can on small baby doses and have a much better outcome than babies who are not treated.
It appears that it's very easy to get these drugs.
The synthetic opioids are produced in factories in by pharmaceutical companies. Some of the worst, most dangerous synthetic opioids now, like carfentanil, which is really an elephant tranquilizer, apparently are coming in from overseas. Somehow it finds its way onto the street and is used to cut heroin and other drugs to make them more potent, and it's accounting for a large number of the deaths. When carfentanil came into one county in Ohio, there were 10 deaths in one day as that drug hit the street. So it's a highly lethal version of synthetic opiates.
And it's not just a U.S. problem.
It's being prescribed more in the Anglo-Saxon world, Australia, Ireland. It's fair to say the U.S. is the world's epicenter of this crisis, but other countries need to learn from it. China recently has taken some measures to shut down those kind of fentanyl producing facilities. So hopefully it cut out some of the sources of this kind of fentanyl. But we don't count on that 100% because fentanyl is so much more powerful than heroin. So a little bit of dosage of fentanyl can go a long way. That makes it easier to smuggle into the US with lower probability of being caught and make much larger profit than heroin. It's like a few $1,000s of purchase overseas if you somehow succeed in smuggling into the US. On the street, it translates to $1.2 million in revenue.
What other options are there for treating chronic pain?
Well, there are some really great substance abuse centers around the country. There has to be a combination, though, of treating the physical addiction with drugs such as methadone or buprenorphine, and also behavioral counseling that goes along with it. That seems to be the best combination. However, these are highly addictive, and so the relapse or recidivism rate is still very high.
It is a very difficult thing to stop once your brain becomes addicted to it, and addiction really is, as the National Institute on Drug Abuse says, a brain disease. The brain physiologically changes in response to the addictive substance, and you can't simply stop as a matter of willpower. So the best route is prevention, and the best route is to try to treat chronic pain with something other than opiates, and that there are a lot of modalities out there. None of them are great, ranging from things like acupuncture and massage and meditation to electrical stimulation of nerves, for example, if there's a nerve that's causing pain and that sort of thing. But the easy thing, I think, from a clinical standpoint is to prescribe an opiate, and that's part of the problem, is that that I would argue at least that they're simply too widely prescribed, and I think that the AMA is now recognizing that. They're backing away from this fifth vital sign notion. Hospitals were actually downgraded if they didn't prescribe opiates a few years ago. It was viewed as an indicator of poor quality, and hopefully we'll change that, and overprescribing of opiates will be viewed as an indicator of poor quality.
That's very interesting.
Yeah, people tend to forget that how effective aerobic exercise will be in controlling pain symptoms. That's the safest approach. I think maybe doctors have given up, encouraging the patient to exercise. They know they won't, so I don't even bother telling you to. But indeed, a long-term solution to that is aerobic exercise, running, swimming, biking.
And that's a difficult thing to tell someone who's in pain, but it really is true that if they got up and moved more, it would relieve their pain, because the body produces endorphins, which are endogenous internal painkillers that don't require a prescription then.
But I don't know that anybody would suggest, at least at this table, that we would completely remove these legal drugs from the market. There are patient populations that truly depend on them. Cancer patients, people that have chronic pain conditions need to be on these drugs long term. I think the problem is the widespread prescribing and the widespread misuse. My son, for instance, had oral surgery recently for wisdom teeth, and he probably only needed to be on a milder painkiller for a few days, but because of our insurance was given a 30-day prescription. So when you think about that, having given a teenager a 30-day prescription, it gives parents pause. I knew enough to get rid of those after a few days and switch him over to something like Tylenol. But we can't say that for everyone in America, and what happens is then we have the supply in almost every household in the United States, and these become very highly sought after drugs because you can sell them for quite a few dollars per pill on the street.
And can you talk about the risks people are putting themselves in when they even experiment with this?
I think particularly among teenagers and people who aren't very well educated about drugs, there's the notion that it's all volitional, and I'll try this, and if I like it, I can continue to use it, and if I don't, I can stop anytime I want to. And they don't recognize what I mentioned earlier, which is that some of these drugs very rapidly change the receptors in the brain to the point where you no longer feel normal or well without the drug, and this is where addiction comes from. It really is a physiological change in the pain receptors in the brain and other receptors in the brain that turn the drug from a special treat, if you will, into a required part of your environment to just feel normal. Then to feel good, you have to have a larger and larger and larger dose of the drug. And that's true of the pain relief too. That's one of the problems, is that for some people, it requires an ever larger dose of the drug to get complete freedom from pain. And at some point you reach the edge of what's called the therapeutic threshold, where the therapeutic dose of the drug and the lethal dose of the drug begin to cross over. And what you need to take to feel okay is potentially life-threatening. And just a little bit of error in how much you take or when you take it can put you into overdose, respiratory depression, cardiac depression, and that's where the Narcan comes in. And if it's available, it can save your life.
Final thoughts as it applies to your research and your practices?
This needs to be a population-wide educational campaign, starting from the teenagers, the school teachers, the healthcare professionals, including the physicians and the nurses. We as a population know too little about this epidemic, and more research is needed, and even more importantly, more education is needed. So teenagers need to know what they might be getting into when the first time experiment is. The school teachers might need to know what kind of crisis are facing their students. The healthcare professionals, the physicians, need to know what kind of long-term implication is when he or she prescribed the opioid medicine. And the nurses, they also, especially those nurses in the emergency department, many of them actually have not learned how to deal with an emergency department visit from this kind of patient. Okay, so that's where I will stop. I mean, the other part is, from my own perspective, like big data helps. The recent interview I did with the Chinese TV that deals with the big, large-scale opioid fraud. So that's the hundreds of medical professionals are giving out this kind of opioid prescription for non-existent appointments. That's something that you cannot easily detect without the help of big data. And people in the federal government look at the volume of prescriptions from a certain physician and find out that something looks funny in a larger prescription amount than the entire hospital. There must be something wrong with that. And then went in and detect and capture a lot of the cases. So that's another angle to look at. I mean, like the people in computer science, the people in data science, they have a role in play to at least reduce to address the problem from the healthcare system side. At least to make the healthcare system a solution, not a problem.
Excellent. Dr. Mayo?
Yeah, I would agree with the prevention aspect and education and starting as early as possible. I would also add that, with our population, if we can educate mothers and let them know how, prospective mothers, how dangerous this can be to newborns. Also, we haven't really mentioned the prescription drug monitoring system that many states have, and that can really help with people going to multiple pharmacies and getting these prescriptions, as well as disposal. I think if we do a better job in educating people on how to dispose of these drugs properly, for instance, many pharmacies will take back your unused opioids.
Yes.
And so letting people know not to keep them at home and how dangerous that is just to have them in your medicine cabinet at home.
Mm-hmm.
Just a couple final thoughts. One of the last days of the legislative session, the South Carolina legislature passed a Good Samaritan law, which tells people who are in a location, a party or something where someone overdoses, that if they call the police or the EMS, that the others at the site will not be arrested for drug possession.
Oh, wow.
So I do not know whether Governor McMaster has signed that into law yet, but the legislature passed it, and we'll be one of the last states to get that sort of legislation through if it is in fact law now. The other thing I would say is I think there are missed opportunities in primary care and in emergency departments to screen people for opiate use and to refer them before the condition becomes so close to lethal to get opioid treatment. But that requires a method to pay for it, and many of these people are uninsured, and with the proposed cuts in the Medicaid system, it's going to be even that much more of a challenge to pay for care for people who are addicted to prescription opiates or to heroin.
Wow. Thank you so much. I really appreciate our panel, our very esteemed panel here with Dr. Hsu, Dr. Mayo, and Dr. Crandall. We want to make sure that you stay posted on all of these important research opportunities here at Clemson University. We'll try to bring them to the forefront. And if nothing else, we'll talk about it. I'm Wanda Johnson.